Hi guys, this is Dr. Nirmal George, your pharmacology faculty at PG now. Today we will be discussing about the INI-CET November 2025 recall questions. So if we take a look at the questions pattern, infections carry the maximum number of questions. Two questions were from HIV, which was repetitive. Last year also there were two questions from HIV. One question was from TB. Two questions were from parasitic infections, which was surprising. One question was from fungal infection. Three questions were from cardiovascular system, of which cardiovascular system as such had two questions, and one question was from diuretics. Central nervous system also had two questions. GIT had one question, and compared to the previous years, there was lesser number of questions from endocrinology. Usually, 2 to 3 questions will be asked in endocrinology. There was one question from migraine, one question from poisoning, which was a multi-system question across various poisonings through various systems, and one question from respiratory system, and one question from anti-cancer drugs. So the difficulty level was from easy to moderate, and 5 questions were from recent advances. The very new drugs were asked, and integration questions were multi-system integration was there in pharmacology, within pharmacology, and integrated questions with microbiology was also there. So let's see what were the questions and what are the answers to that questions. The first question is, which of the following statements regarding rimegepant is correct? So rimegepant is an agent that is used for the treatment of migraine. So in migraine, the trigeminal nerve releases a neurotransmitter called as CGRP, and it is implicated in the pathophysiology of migraine. And CGRP act on a receptor called as CLR receptor, that is calcitonin receptor-like receptor. And rimegepant is a CGRP antagonist, and it was the first agent which was approved for both the prophylaxis and also for the treatment of migraine. And there are other CGRP antagonists available: ubrogepant, atogepant, and savigepant. And this rimegepant is available as an orally disintegrating tablet. So the options are: it is administered subcutaneous. That is wrong because it is available as an orally disintegrating tablet. It is indicated for the acute management of migraine. That is true. It is indicated for the management of both acute attack as well as prophylaxis of migraine. It is given as it is a CGRP1 receptor agonist, which is wrong, which is a CGRP receptor antagonist. And it produces vasoconstriction. So the vasoconstrictor agents which are used in migraine are triptans, and they act on 5-HT1B1D receptors, and they act as 5-HT1B1D agonists, and they produce vasoconstriction. So the use of triptans produces vasoconstriction, and it can produce large number of cardiovascular adverse events. But this rimegepant, it entirely blocks the pathophysiology of migraine. So it is a very great, useful option in both prophylaxis and also for the treatment of migraine. So rimegepant is indicated for the acute management of migraine. That is option B. The next question is false statement regarding dronabinol. So dronabinol is a synthetic tetrahydrocannabinoid, and cannabinoids, they act by acting on two receptors, CB1 and CB2. Dronabinol is a partial agonist at CB1 receptors, and it is not water soluble, so it is available as a soft gelatin tablet, soft gelatin capsule, and this formulation is in sesame oil. And this has got extensive first pass metabolism and very low bioavailability of 20 to 30%. So it is preferably taken on an empty stomach. And it is approved for 2 indications, and it is used off-labelly for another indication. It is approved for HIV-related anorexia because cannabinoids will increase the appetite and food consumption. So HIV-related anorexia, HIV-related weight loss, malignancy-related weight loss. And it is also used to terminate the to reduce the symptoms like nausea and vomiting in chemotherapy. And the major adverse drug reaction of this dronabinol is neuropsychiatric manifestation. So if we are seeing the options, False statement regarding ronavirus. It is used for chemotherapy-induced vomiting. That is true. It is excreted unchanged in urine because it is extensively metabolized by the liver. It is not excreted unchanged in the urine. And it is a cannabinoid receptor agonist. That is partially correct because it is a partial agonist of CB1 receptor. If you are taking B and C, B would be entirely wrong. And the fourth option is it is approved for weight loss in HIV. That is also true. So the option is B. It is excreted unchanged in urine. Next question, which of the following statements about rifampicin is incorrect? Rifampicin is a first-line agent used for the treatment of tuberculosis. So the resistance to rifampicin, it occurs by mutation of RPOBG. That is correct. It undergoes enterohepatic recirculation or enterohepatic cycling. That is also correct. It should be administered along with fatty meals because rifampicin, the bioavailability is reduced to approximately 30% when it is consumed with food. So all the anti-tubercular drugs, they are used on an empty stomach, or they are administered on an empty stomach. Its CNS penetration is limited by P-glycoprotein. So rifampicin has got high plasma protein binding, so the CNS penetration is very low. And even if some rifampicin gets into the CNS, the P-glycoprotein will pump this rifampicin back into the systemic circulation. So it is limited by P-glycoprotein. So the correct option would be, it should be administered along with fatty meals. That is entirely wrong. It should be administered on an empty stomach. The next question, this is a repeat question. Last year also the same question was that HIV-TB co-infection. A patient with HIV presents with 3-month history of cough, fever, miliary tuberculosis is suspected. What should be the next step in management? So when, in case of this co-infection, HIV and tuberculosis, the symptoms and lung damage or damage due to tubercle bacilli is most commonly due to the response of the natural immune system. So this HIV will reduce the natural immune response. So the symptoms and also the damage to the organs by the tubercle bacilli will be limited in this co-infected condition. So if you are treating HIV, this will result in improvement in immune function, and that will result in rapid worsening of the symptoms and also the damage to the organs produced by the tuberculosis. So this is known as IRIS, or immune reconstitution inflammatory syndrome. So to prevent that, when there is co-infection of HIV and TB, you have to always treat TB first, and then after 2 weeks, you have to start HIV treatment. And in these options, starting ATT first is only seen in the first option. So that would be the appropriate response. So since this ATT contains rifampicin and dolutegravir is a first-line agent for the treatment of HIV, this dolutegravir is metabolized by liver, and rifampicin will induce the metabolism of dolutegravir, and that will reduce the plasma concentration and reduce the efficacy. So you have to increase the dose of dolutegravir. And you have to give dexamethasone since it is miliary tuberculosis. So you have to reduce the inflammation and also the damage. So you can use dexamethasone. So the correct option would be A. You shouldn't start antiretroviral therapy first. So the option B is wrong. Administer an increased dose of dolutegravir immediately. That is also wrong. Initiate ART and ATT simultaneously. That is also wrong. So the correct option would be A. Which of the following medications act by inhibiting vascular endothelial growth factor? So ranibizumab, it is a monoclonal antibody which acts on VEGF-A, vascular endothelial growth factor A, and it is mainly used for retinal condition like wet macular degeneration, macular edema, diabetic retinopathy, diabetic macular edema, retinal ischemia, etc. So that would be the correct option. Pembrolizumab is a monoclonal antibody which targets it is an immune checkpoint inhibitor. It targets the protein programmed cell death protein 1. It is mainly used in various number of carcinomas, melanomas, non-small cell lung carcinoma, squamous cell carcinoma, renal cell carcinoma, etc. Ipilimumab, it is a cytotoxic T lymphocyte associated protein 4 inhibitor, that is an immune checkpoint inhibitor. It is approved for the treatment of malignant melanoma. Dostarlimab, it is also an immune checkpoint inhibitor. It acts on the programmed cell death 1 protein. It is approved for the treatment of endometrial carcinoma. So the correct option would be ranibizumab. Which regimen is considered the preferred treatment for cryptococcal meningitis? So cryptococcal meningitis, it occurs in immunocompromised patients, especially HIV patients, and two species are known to produce meningitis, neoformans and GAT-T. And amphotericin B is the first line agent for the treatment, and amphotericin B should not be given alone, it should be combined with flucytosine. So the ideal combination, ideal preferred formulation of amphotericin B is amphotericin B deoxycholate with flucytosine. But if deoxycholate is not available, you can use liposomal amphotericin B lipid complex, etc. And in patients who cannot use flucytosine or who cannot tolerate flucytosine, you can use liposomal amphotericin B alone also. So in this case, this would be the appropriate option, liposomal amphotericin B with combination of flucytosine. Fluconazole is used for consolidation therapy and also maintenance therapy of cryptococcal meningitis. Fluconazole alone. So identify the parasite in the image and select the most appropriate drug for its treatment. So this is a freshwater crab. It transmits lung flukes. The Paragonimus species is transmitted by this freshwater crab. And the treatment of choice in this condition would be praziquantel. All the flukes are treated with praziquantel. And there was this dose response curve in which acetylcholine was given, and the log dose response curve show a sigmoid curve. And acetylcholine, when it is combined with another drug, it increases the response of acetylcholine. So most possibly, this would be an agent that will improve the response of acetylcholine. And physostigmine is a reversible acetylcholine esterase inhibitor. So it inhibits the acetylcholine esterase and thereby reducing the degradation of acetylcholine. So the dose response curve will shift upwards. Bethanacol is a muscarinic receptor agonist which acts on M3 receptors, and it acts predominantly in the bladder. It improves the detrusor muscle contractility. And adrenaline and acetylcholine, they act on different receptors, so there won't be any response like this. And atropine, it is a competitive agonistic muscarinic receptor, so their response would be in the opposite direction. So the correct option is physostigmine. Which of these drug combination is recommended for HIV pre-exposure prophylaxis in individuals at high risk? So for pre-exposure prophylaxis, two drug combinations are used. One is tenofovir plus impricitabine or tenofovir plus lamivudine. Both these combinations can be used, and both these can be the correct answer. Which of the following parasitic infections is most effectively treated with ivermectin? So strongyloids respond to ivermectin. Trichinella, the treatment is with albendazole. Loa is treated with DEC. So the first option is eliminated. Strongyloids is treated with ivermectin, but Trichinella cannot be treated with albendazole only. Loa can be treated with DEC. Brugia can be treated with DEC. So this option is also out. The third option is Onchocerca volvulus, which is treated with ivermectin. And Loa is treated with DEC. So this third option is also eliminated, and that the fourth option would be the right one. Ivermectin is not very effective in killing the adult worms, but it is very effective in microfilaria. It can kill the microfilaria. So this would be the right option. And there was this one question where a transporter was given where sodium was moving to the extracellular and potassium was moving intracellular, and there was expenditure of ATP. So this would be a sodium-potassium ATP channel, which is predominantly present in the heart. And there was this another question where it was asked which drug would be acting by this mechanism, sodium-potassium ATP. So inhibitor of sodium-potassium ATP is digoxin, used for the treatment of cardiac fever. Which statement accurately differentiates finerenone from spironolactone? So there was this word accurately. So finerenone is a mineralocorticoid receptor antagonist and is very highly selective. It is a non-steroidal agent. And compared to spironolactone, finerenone has got action on both kidneys and also in the heart, whereas the spironolactone has got predominant actions in the kidney. And spironolactone has got steroidal structure, so it will act with the steroidal receptors, especially estrogen receptors, and cause gynecomastia. Finerenone has got lower risk of gynecomastia. And compared to spironolactone, finerenone has got a shorter half-life and lower risk of hyperkalemia. And finerenone is approved for the treatment of cardiac failure and also chronic kidney disease. So the options are spironolactone causes lower gynecomastia compared to finerenone. That is completely wrong. Both drugs are mineralocorticoid receptor antagonists, but finerenone is non-steroid. That is true. Finerenone is non-steroidal selective mineralocorticoid receptor antagonist with fewer endocrine side effects. That is also true. Finerenone inhibits aldosterone synthesis. That is wrong. It is an aldosterone receptor antagonist. So when you are comparing both the options B and C, C would be a more appropriate option because the question is which statement accurately differentiate finerenone. So finerenone has got lower endocrine side effects as well. So the next question, which of the following adverse effects is not associated with the use of inhaled beta-adrenergic receptors? Okay, so pulmonary vasodilation, that is the first option. So beta-2 adrenergic receptors, they can act on the beta-2 receptors in the pulmonary blood vessels and cause pulmonary vasodilation. Then beta-2 receptor agonists, they are not completely selective for the beta-2 receptors. It can also act on the beta-1 receptors of the heart and can cause tachycardia. So it can produce palpitation. It will also act on the beta-2 receptors in the skeletal muscles, thereby producing muscle contraction. It will activate the sodium-potassium ATPase, where sodium will be pumped out and potassium will be pumped into the muscles. So that can result in tremors. So since potassium moves from the extracellular to the intracellular, these beta-2 agonists, beta-adrenergic agonists, they will produce hypokalemia. So this is not a hyperkalemia is not associated with the use of inhaled beta-adrenergic agonists. A chronic schizophrenic patient on haloperidol presents with stiffness and rigidity. On investigation, CPK was raised. Which of the following treatments is most appropriate? So stiffness and rigidity is due to the dopamine receptor blockade, and this is an extrapyramidal symptom. And CPK was raised probably because of the excessive muscle contraction that will lead to rhabdomyolysis and elevation of the CPK. So this would be neuroleptic malignant syndrome. Okay. So there will also be rise in body temperature. There will be alteration in cardiovascular parameters like pulse rate, blood pressure. So this is commonly seen with the use of first generation antipsychotics like haloperidol. So first thing when you are managing this neuroleptic malignant syndrome is that you have to stop the offending drug, that is haloperidol. That should be the treatment of choice. And then you have to use a directly acting skeletal muscle relaxant like dantrolene. If dantrolene is not available, you can use agents that will modulate the restore the dopaminergic activity in the central nervous system. That is like bromocriptine or amantadine. So bromocriptine along with stoppage of antipsychotic drug would be the appropriate treatment. You can also use benzodiazepine. Since the muscle is contracting so much, you can use benzodiazepine for muscle relaxation and also sedation. You have to admit the patient immediately. You have to do ICU admission. Next question. Which of the following is not a benefit of using ketamine? So ketamine is a anesthetic agent. It is a NMDA receptor, glutamate receptor antagonist. It is commonly used as an inducing agent. And when you're giving ketamine, what happens is that the person will go into a trance-like state where the person is having analgesia, amnesia, but he is having reduced movements and lower excitability to stimulus. And when this is happening, the person's eyes will be wide open, so he won't be responding to any of your stimulus. So it will look as if the person has gone out of his body. So that is why it is called as dissociative anesthesia. So these this ketamine, when it is used, it can reduce the central pain sensitization. So it can potentiate the effects of opioids. And so if you're seeing the options, it is used as an induction agent. Yes, that is true. It enhances the effect of opioids. Yes, it induces dissociative anesthesia. Yes, it reduces opioid tolerance. When in patients who are receiving opioids, there is increase in pain sensation that's called as hyperalgesia. But and also this produces dependence as well. So ketamine can be used in this condition, but the effect of ketamine to reduce this opioid dependence, tolerance, or hyperalgesia is very weak and very inconsistent. So this would be the right option. Option D. Match each poison with the corresponding antidote. This was a question across various systems. We all know that the antidote for methanol is fomepizole. So A4 is seen in three options, B, C, and D. So you can eliminate A. Oh, and antidote for opioid is naloxone. So B would be 3. So that option comes to option D. And arsenic can be treated with antidote for arsenic poisoning is British anti-Lewisite. And the antagonist of benzodiazepine is flumazine. So this is option D. And this question, which DPP inhibitor requires dose modification when used with ketoconazole? So ketoconazole is a microsomal enzyme inducer, and it will induce various microsomal enzyme and increase the metabolism of many drugs. And among the DPP-4 inhibitor, only one DPP-4 inhibitor is metabolized by the liver, that is saxagliptin. Others are eliminated more or less by less amount of metabolism and more in the urine. So these are the questions that we could get from a recall of various students. And I believe that there are some other questions as well. So I hope the exams were good for you and you did very well. Thank you.